Hey everybody, Dr. Becker. I'm so happy to be at this stage with you guys, as I'm sure you are as well by the time you're listening to this. We're almost at the end of the semester. We're jumping into these last three chapters. They're all kind of small and straight to the point, so they go well to be grouped together. The first one we talk about is drugs that affect the eye. The big disease we talk about to start off with is glaucoma. Glaucoma refers to a group of diseases characterized by decrease in your peripheral vision secondary to optic nerve damage. The most common forms of glaucoma are the primary open-angle glaucoma and then the acute angle closure glaucoma. And they are quite different, and they're different in their pathology, and therefore they're also different in their treatment. Glaucoma is something you are going to encounter in practice. It's the leading cause of preventable blindness in the United States. About 120,000 roughly Americans are blinded each year by glaucoma, and about 90% of those could have saved their sight with timely treatment. So this is really important that we understand how to treat the glaucoma and how to recognize it and how to educate our people on why we check for it, because you can save their eyesight. About 4 million people with glaucoma, about only 50% are diagnosed at any one time. So they first start by making sure we understand and review the aqueous humor and its role in maintaining our intraocular pressure, which is what I mean IOP. So this is table or figure 87.1 in your book. And what it's showing here is that the aqueous humor in here is produced by the ciliary body and secreted into the posterior chamber of the eye, right? Posterior chamber of the eye is in here. So this is where the flow of the aqueous humor comes in right here. From there, it circulates around the iris into the anterior chamber, and then it exits the anterior chamber through the trabecular meshwork and the canal of Schlemm. I love that name, canal of Schlemm. If outflow from the anterior chamber is impeded, the back pressure will develop and your intraocular pressure will rise. Conversely, if your production of aqueous humor falls, your intraocular pressure will decline. So characteristics of the primary angle, open angle glaucoma, POAG. So the POAG is the most common form of glaucoma. That's important to know. It's about 90% of glaucoma is the POAG, and therefore it is the leading cause of blindness in the United States. It's characterized by the progressive optic nerve damage with eventual impairment of vision. The visual loss develops first in your periphery, and as it advances, the loss then will occur in the central visual field. The pathologic process that leads to the optic nerve damage we don't completely understand, but we know that the intraocular pressure is often elevated, but it could also be normal. Don't you love that when there's those gray areas? The other thing about it is POAG is painless and insidious, and it takes years to develop the nerve injury. So often, symptoms are absent until you have extensive nerve damage already, which is why regular eye doctor exams are important and they're checking your intraocular pressure because you may not know that you are even developing symptoms of glaucoma. But how do we manage it? So treatment of the POAG, is directed at reducing our elevated intraocular pressures, the only risk factor we can modify. So although this has no cure, the reduction of your intraocular pressure can slow and even stop progression. And it's usually managed by specialists. But primary care providers often will play a role in the ongoing monitoring or following up of the medications, especially if you're in rural areas. So the principal method for reducing intraocular pressure is chronic therapy with drugs. Drugs will lower the intraocular pressure by either facilitating aqueous humor outflow or reducing the aqueous humor production. So if you go to table 87.1, you'll see that table there that outlines these drugs for glaucoma. And there's three main classes. We have the beta adrenergic blocking agents, beta blockers, alpha 2 adrenergic agonists, and then we have our prostaglandin analogs. We do have some options with cholinergic drugs and the carbonic anhydrase inhibitors, but those are second line choices. So your first line choices, beta blockers, alpha 2 adrenergic agonists, and prostaglandin analogs. All of the drugs, the preferred route is going to be topical. For more than 25 years, the beta blockers, i.e. timolol, were considered the first drug of choice. But the alpha 2 agonists, which is brimonidine, and the prostaglandin analogs, which is latanoprost, which is the one I'm more familiar with, are just as effective as the beta blockers, and they have a better side effect profile. They work by different mechanisms, and so combination therapy can be even more effective than monotherapy. And because they're only topical in the eye, they tend to be pretty low in systemic absorption, but you could have some side effects systemically. That table is a great table in your book that will really show you what the classes of the drugs are and all of that. If your drugs that you're using are unable to reduce your intraocular pressure, surgical intervention to promote the outflow of the aqueous humor is indicated. So that could be trabeculectomy or a laser trabeculoplasty. But in other words, you start with drugs. We talked about the first line drugs. If they don't work, then oftentimes they have to have some kind of surgical intervention. Okay. Notice that the beta blockers can be non-selective, like the timolol is the very common one that we will use. They does have the possibility if people do actually absorb enough to have issues with heart block, bradycardia, or bronchospasm. So they may not be the best drugs of choice for you with certain classes of patients. And then the prostaglandin analogs can have a heightened brown pigmentation of the iris and eyelid. And that's really important to educate people on. And that's, to me, that's a mutual decision you and the patient have to come to an agreement that that's an okay side effect for them, because we have other choices sometimes. So don't just give it assuming, well, they're going to have to deal with it, because if it happens, they could be upset by it. And then the alpha 2 adrenergic agonists can cause some dry mouth, headache, dry nose, altered taste, conjunctivitis, etc. And those kind of side effects may be something that prevent them from really wanting to stick with that drug. The muscarinic agonist, which is a second line choice, like pilocarpine is one I see a lot, but that can cause miosis or blurred vision. The carbonic anhydrase inhibitors, like dorzolamide, I see a lot, or acetazolamide, that can cause some stinging, but it can also have a bitter taste or some lid reactions. So again, the main thing is we want to know what POAG is, understand the pathophysiology, and understand the purpose of the drugs, which we are giving to decrease the aqueous humor formation so it can't raise and cause the problems with the damage to the nerves. Okay, next we go into angle closure glaucoma. And this is precipitated by the displacement of the iris so much that it covers the trabecular meshwork and prevents the aqueous humor from the anterior chamber. So as a result of that, the intraocular pressure increases rapidly into a very dangerous level. And that's why it's called angle closure or narrow angle glaucoma, because the angle between the cornea and the iris here is greatly reduced. Angle closure glaucoma develops suddenly and it's extremely painful. So in the absence of treatment, its irreversible loss of vision will happen within 1 to 2 days. It's much less common, right? It's like only 10% of glaucoma is going to be in this category, but it's certainly in your differential of what you're thinking of if you have a patient who develops an extremely painful eye with loss of vision. The treatment for the angle closure glaucoma then consists of drug therapy to control the acute attack, and then you have to have corrective surgery. So you can use a combination of drugs, osmotic agents, short-acting miotics, the carbonic anhydrase inhibitors, to suppress the symptoms. And then after you've been able to reduce the intraocular pressure, then you have to have a definitive treatment, like an iridectomy or a laser iridotomy with your iris. Okay, so let's talk about these drugs then more by the classes here. So our beta adrenergic blocking agents, okay, is a topical dose. Table 87.2 goes through and talks about that. The beta adrenergic blockers will lower your intraocular pressure because it's decreasing the aqueous humor. Reductions in that will be with non-selective beta blockers as well as cardioselective beta blockers. Remember, beta blockers are primarily for the open angle glaucoma, but we do have some second choices, and a lot of times they may be used in combination. Adverse effects potential for the beta blockers include local, so you can have some transient stinging or some blurred vision or some like photophobia or dry eyes. There is a possibility to have some systemic absorption, and so you can still have trouble with blood pressure. And in the book, it talks about that the timolol, that instilling 1 drop of the 0.5% timolol in each eye can produce the same blood levels as taking the 10 milligrams of timolol by mouth, which is a starting dose for hypertension. So you could have systemic effects on heart and lungs. So you could have bradycardia or AV block. So for patients that have dysrhythmias, this may be maybe the beta blocker agents are not the best choice for them. Maybe with heart failure, that's not the best choice for them. Also, the beta blockade of beta 2 receptors will cause bronchospasms in the lung. Constriction of the bronchi can occur with beta 1 selective as well as the non-selective, although the risk is always going to be greater with the non-selective. Only one ophthalmic beta blocker is betaxolol is beta 1 selective, so that's the drug that's preferred with asthma or COPD. So betaxolol is a beta 1 selective ophthalmic glaucoma medication, and it can be safe to use with asthma and COPD. The prostaglandin analogs, we have 4 of those that are on there. They are just as effective as the beta blockers, but can have fewer side effects. So sometimes these are the better route to go for people, especially if they have heart issues or lung issues. They're still considered first-line treatment, like latanoprost, travoprost, bimatoprost. The drug they use in your book is latanoprost, which is Latin. It's an analog of the prostaglandin F2 alpha, and it was the first drug of this class. It's applied to help lower the intraocular pressure in patients. And again, it facilitates the aqueous humor outflow because it relaxes the ciliary muscles. Oftentimes, it's recommended to take your dose in the evening, and sometimes, and that really is the best time to take it. That's what I was trying to say. It's pretty well tolerated, and it doesn't really tend to have the systemic reactions. The most significant side effect is considered harmless, but could be distressing to a patient, and that's the heightened brown pigmentation of the iris, which is most noticeable in patients who have green-brown or yellow-brown or blue-gray-brown eyes. It's less common to see it in blue or green or blue-green eyes. Heightened pigmentation stops progressing when the latanoprost is discontinued, but it doesn't usually regress. And so it could increase the pigmentation also of the eyelid, may increase the length and thickness and pigmentation of the eyelashes. So for some people, it is distressing. It can also have blurred vision, burning, stinging, some edema, and very rarely can cause macular edema. Then other prostaglandin analogs are listed in your book there. And I just wanted to point out that they do, in fact, talk about bimatoprost, which is marketed as Latisse, which maybe some of you have heard of because it's used for the specific purposes of increasing eyelash length, darkness, and thickness. And it's actually a glaucoma drug. All right, then our alpha-2 adrenergic agonists, apraclonidine, is used only for short-term therapy, but the other agents like bromonidine has first-line drug therapy and long-acting long-term. It's also available over the counter as Lumify, which is interesting to me. So let's talk about bromonidine. Is Alphagan, typically, is the trade name you may hear. It can be used for long-term reduction of the elevated intraocular pressure for both open-angle glaucoma or ocular hypertension. The drug lowers the intraocular pressure by reducing the production of aqueous humor and perhaps by increasing outflow. It may delay optic nerve degeneration and protect retinal neurons from death. The most common adverse effects could be your dry mouth, ocular hyperemia, so turning more of a jaundice, local burning, stinging, blurred vision, foreign body sensation, and itching. Bromonidine can cross the blood-brain barrier, so it can cause drowsiness, fatigue, or even possibly hypotension. Remember that the activation of our alpha-2 receptors in the brain decreases their sympathetic outflow to blood vessels and can decrease blood pressure. And bromonidine can be absorbed onto soft contact lenses, so you need to wait at least 15 minutes between putting in the drop and then using your contacts. And then we have combination drugs that are on the market now, and that's because we know that 2 drugs tend to work better than 1. So that table 87.4 in your book goes through those. Direct-acting muscarinic agonist is pilocarpine. It's a parasympathomimetic agent. It is widely used, but it's still now considered a second line for the open-angle glaucoma, but it can be used for emergency treatment of acute angle closure glaucoma. So if you were to be asked, is there a drug that can be used to treat both open-angle glaucoma and an acute treatment for angle closure glaucoma, pilocarpine would be a good answer. It's still topical. By stimulating the cholinergic receptors in the eye, the pilocarpine produces 2 direct effects. One is miosis, so you get constriction of the pupil. And then 2, it will cause contraction of the ciliary muscles, which is an action that focuses the lens for near vision. And intraocular pressure is lowered more indirectly. And by that, they mean that the intraocular pressure is actually reduced because there's tension generated by contracting the ciliary muscles, which promotes widening of the spaces within that trabecular meshwork, which thereby facilitates outflow of the aqueous humor. So it does work, but it's a little more roundabout way to get there. The major side effects of pilocarpine for the eye is that it can cause problems with your near vision. And so some people have to have corrective lenses just for their near vision. It can also occasionally cause sustained contraction of the ciliary muscles, which could lead to retinal detachment. That's kind of a big deal. And the constriction of the pupil may decrease your visual acuity, like we said. So it also can cause irritation, eye pain, and a brow ache. So it's a great drug. It can work very well. It has recommended uses. You will see people on it, but it is a second-line agent because it's less direct to affect your open angle, and it's got more potential for side effects and some more adverse reactions than people might like. It rarely can cause systemic side effects, but it can, and that could be reversed with atropine. Okay. Then we have a cholinesterase inhibitor, which is ecothiopate. Geez. It's phospholine iodide is how I've always heard it too. So ecothiopate. Gee, many Christmas. Ecothiopate. I cannot say that 10 times fast. So it's indicated for our primary open angle glaucoma, but because of concerns about its possible adverse effects, it's not a first-line choice. It's reserved for patients who have poorly responded to the first-line medications. It does have a long duration of action, and so it could be helpful in some ways that way. Remember, a cholinesterase inhibitor inhibit the breakdown of acetylcholine by cholinesterase and thereby promote accumulation of acetylcholine at the muscarinic receptors. So as a result, they can produce the same ocular effects as the pilocarpine, like miosis or focusing of the lens for near vision, and therefore could also reduce the reduction of your intraocular pressure. But it can also cause myopia, like double vision, and excessive pupillary constriction. But there's greatest concern between a long-acting cholinesterase inhibitor and then the development of cataracts. So we have to be careful with that as well. It also has the potential to be systemically absorbed, and so that can cause some of those parasympathomimetic responses like bradycardia, sweating, salivation, diarrhea, urinary urgency. So it's not always tolerable for people. Next one is the carbonic anhydrase inhibitors, which is a topical. They tend to be less effective than any of the other ones, so some people throw it out there as a possible option. The next one is the specific is dorzolamide, and that was the first carbonic anhydrase inhibitor available for topical administration. It does reduce the production of aqueous humor. It's generally well tolerated, but side effects are ocular stinging, and people report a bitter taste immediately after. Some people have also had allergic reactions to it, or it can cause like a conjunctivitis or an infection or irritation of your eyelids. So it's not always well received. But it is often given, it can be given, I've seen it a lot, in a fixed dose combination with timolol, so a beta blocker, and that's marketed as COSOPT. And the combination produces a greater reduction than either one alone. And so I've seen people on the COSOPT quite a bit, and in my anecdotal experience, I haven't seen people not really tolerate it well. So I see it a lot. And again, these drugs, which the dorzolamide and the brinzolamide can absorb in soft contact lenses, so you have to wait those 15 minutes between. The oral carbonic anhydrase inhibitors have been mostly replaced by the topical drugs, but remember acetazolamide and methazolamide are often can be given as an oral systemic treatment for glaucoma. So remember that there are some pills form. You may have somebody who's taken an oral pill for their glaucoma. It's not going to be first drugs of choice, and they're reserved as like the last ditch effort for some patients. And then we have the RHO kinase inhibitor, which is notarsidil, Rhopressa. That came out in 2017. It decreases intraocular pressure by increasing aqueous humor outflow through that trabecular meshwork. But the exact mechanism by that and how it works is we don't really know. It works. It can cause some eye discomfort, but there are few adverse effects. Subconjunctival hemorrhage may occur, and while it's visually disturbing, it's not a serious condition, and they're still following that closely as of the time of this book posting. Some of the points for patient education in your book I'd like for you guys to be able to review. It's really important to take the prescribed medication according to schedule. Because you can have loss of vision. You have to notify the provider immediately if you do lose your vision, if you have severe pain, headache, nausea, vomiting, because it could actually mean that you have developed angle closure glaucoma. If photophobia is a problem, you could wear sunglasses, a wide-brimmed hat, a visor, etc. Check the labels of the ophthalmic drugs to see if they contain the benzalkonium, because that's the preservative that can interact with the soft contacts. Take care not to touch the dropper to the eyes and not to touch the tip with your fingers, because contamination can cause eye infection. To improve topical absorption and minimize systemic absorption, close the eye for 3 minutes after administering the eye drops and lightly press a thumb or finger over the medial canthus, which is the inner corner of the eye. Glaucoma is going to be managed by a specialist, but that does go in there and tell you all about the key prescribing considerations, which are helpful to review and kind of all puts this together. So that's our glaucoma. It's kind of fast and furious here, but just remember which drugs are your first line, which drugs are your second line, and then some of those idiosyncrasies and nuances of the drugs we've talked about. The next condition that falls under eyes that you may be treating and you're going to be seeing possibly a lot of are allergic conjunctiva. It's often referred to as AC, air conditioner. No, it's allergic conjunctivitis. So that is inflammation of the conjunctiva in response to an allergen. Duh. It could be seasonal, but it could be perennial, chronic. The primary symptoms, right? We know this: itching, burning, discharge, watery discharge, and then the conjunctiva look red and congested. It's pretty miserable for people, and it comes as a result from a biphasic immune response. Okay, so initially the symptoms are caused by the release of your inflammatory mediators, right? So if we're thinking allergen, we're thinking histamine, prostaglandins, all the kinins, all those things, right? So you get those inflammatory mediators are released. Those mediators will stimulate your mucus production, so you get the watery discharge. They'll activate the nerve endings, which cause them to itch and burn, and then they'll promote vasodilation and they increase capillary permeability, so you get redness and congestion. So those symptoms peak about 20 minutes after the allergen exposure, and they should abate about 20 minutes later. But after that early response, the symptoms typically reappear within 6 hours or more. And the late phase then is due to recruitment now of our immune cells, like our eosinophils, neutrophils, and macrophages, that amplify then the inflammatory response. It's important just to remember that process, because then that can help you understand why we would use the drugs we use for allergic conjunctivitis. So it can be managed by a variety of topical drugs, right? Table 87.7 is going to be your friend in this. There's a couple of different classes of drugs. So the first one is mast cell stabilizers, like cromolyn. Those prevent the release of those inflammatory mediators. So hopefully we're cutting off at, the snake at the head. The patient should be informed that the benefit can take several days to develop and 2 or more weeks to become effective. But in contrast to mast cell stabilizers, we can have histamine 1 receptor antagonists, or our antihistamines, that can provide immediate symptomatic relief. Some drugs, winky winky, have both actions. They can block H1 receptors and prevent the mediators from the mast cells. So I love those, and that's like azelastine or olopatadine. Those drugs are really good choices for allergic conjunctivitis. They work well. Also, ketorolac is a nonsteroidal anti-inflammatory drug that could reduce the symptoms by inhibiting the cyclooxygenase, the COX, which is that enzyme that we know is required for synthesis of prostaglandins. So you have your mast cell stabilizers, your H1 receptor blockers, and then your H1 blocker with the mast cell stabilizing properties. If I were a patient, I would really love to be given an H1 blocker with a mast cell stabilizer, because to me it's like, yeah, now we're hitting it on both levels and I can get immediate relief and long-lasting relief. A lot of the drugs also used, though, are glucocorticoids that can be given as well for that. And then we also have the option of ocular decongestants, or a decongestant and an H1 blocker together, which I also think is a great choice. So like an NSAID, the glucocorticoids inhibit the production of those prostaglandins. So they inhibit the production of leukotrienes and thromboxane, and so they're really effective drugs. The ocular decongestants, like phenylephrine, decrease the redness and edema by activating that alpha-1 adrenergic receptor on blood vessels, causing vasoconstriction. So the benefits are only symptomatic, and these drugs do not interrupt any phase of the immune system. So with regular use, that's where you get rebound congestion is most likely. So for this reason, short-term use for no longer than 2 weeks is recommended. So the good thing is you can use those, and oftentimes that's the time you need to get the mast cell stabilizers to be effective, which is great. But you really have to pay attention and educate your patient that they should not take those long-term. Then they get stuck in that vicious cycle of rebound congestion, and it's pretty awful. Okay. They give us a lovely flow here of how to work the algorithm of ocular allergy treatment. Okay, So first of all, we have over-the-counter options: lubricants, topical decongestants, topical antihistamines, cool compresses, or oral antihistamine. Okay, but if they come to you and they're pretty miserable, we do have options, as we talked about now, for prescriptions. Okay, mild symptoms would be like mild itching that's intermittent or short-lived. Moderate symptoms would be mild to severe itching that lasts a few days to 2 weeks without eye redness. And then severe symptoms are moderate to severe itching that is chronic with eye redness. So you do a good history and review of symptoms with the patient, and you determine, okay, are we mild, moderate, or severe? And you can notice that mild, they're pretty okay with still using our over-the-counter medications, or to avoid the allergen, right? Well, that makes sense. And then think about our contact lenses and whether or not those could be worsening or irritating or trapping the allergen in our eye. If they have moderate symptoms, then they start talking about still the potential for over-the-counter, avoidance, multiple action agents. We want preservative-free agents, and then we can even consider immunotherapies. If these people have severe kind of refractory symptoms, we talk topical steroids, oral steroids, immunotherapy, again, preservative-free agents, and even topical cyclosporin. So that's a nice little algorithm for y'all to have there too. So the goal of treatment for allergic conjunctivitis, if they said, what's your goal here? What are we trying to achieve? We're trying to relieve the symptoms of itchiness, discharge, and redness, and we want to prevent associated complications that occur secondary to eye irritation or vigorous eye rubbing. Go off on a little tangent here. Maybe you haven't seen this in practice, or maybe you haven't experienced it in friends or family, or maybe in your personal life. If you have not seen the complications that can come by a secondary infection to your eye, well, then you're lucky, okay? It is bad. Like when people tell you wash your hands before you put your contacts in, don't touch the eyedropper to your eye, I think we sometimes approach it lackadaisically. I can guarantee you, if you know somebody that has had a secondary eye infection that gets gnarly and bad and like dangerous, where they lose their vision or they lose their eye, they wish they could go back to good hand hygiene and not itch and scratch their eyes, okay? So I'm saying that because it is a really important piece for you guys to burn into your brain. Like, be good providers and really educate patients that you have to take good care of your eyes. We want good eye health. And if you get a secondary infection in your eye, it's bad. They're painful, they itch, they burn, they take a long time to go away, they can be expensive, and they can get so bad, people can lose their vision or their eye. So there's my little soapbox. If you have a patient that is using topical glucocorticoids, you have to assess for evidence of eye infection. That does place them at risk for eye infections and for some of the worsened type of eye infections like herpes or a fungal infection or whatever. So the topical glucocorticoids have to be used cautiously. The ocular decongestants are contraindicated if anybody has a history of angle closure glaucoma. So that's a big deal. The glucocorticoids may increase your intraocular pressure if they're used long term. Mast cell stabilizers take time. And then you have to educate the patients so that they're not like quitting after 7 days because they got no relief. Okay. And then there's a good section in your chapter 2 I wanted to point out about your allergic conjunctivitis and patient education. That's really good. You can review that. It kind of just puts everything through that we talked about. Again, we prescribe both farm interventions and non-farm interventions. So think about avoiding allergens, think about cold compresses can help with discomfort, help about taking a break from contact lenses, some of those things, and then literally trying to avoid your allergens, right? That's a good idea too. And then the other common condition we see a lot in practice is the idea of dry eyes. So ophthalmic demulcents are artificial tears. And those are isotonic solutions that substitute our natural tears. Most of the preparations contain polyvinyl alcohol, cellulose esters, or both. And so artificial tears are indicated for relieving dry eye syndromes and discomfort or dryness caused by irritants, wind, or the sun. Demulcents may also be used to lubricate artificial eyes. Artificial tears, though, are devoid of adverse effects and may be administered as often as long as desired, which is nice. So it's a pretty safe thing to do. Restasis is a prescription for dry eyes from inflammation. So it's a topical cyclosporin ophthalmic emulsion. It suppresses the immune system, thereby promoting resumption of tear production. So despite its mechanism of action, they have not identified an increased risk of ophthalmic infections with it. So it's a pretty safe drug to use, and it can still, though, cause eye discomfort, itching, and blurred vision. And then remember our ocular decongestants are weak solutions of adrenergic agonists applied topically to constrict the dilated conjunctival blood vessels. So they're going to reduce the redness of the eye by minor irritation. So phenylephrine, oxymetazoline, those are some of the normal ones I see. When they're in low concentrations like the eye drops, they typically have rare adverse effects. Glucocorticoids, we're going to review this one more time. So remember, we use these to treat inflammatory disorders of the eye. So that can also include iritis or uveitis, right? Short-term therapy in the absence of infection is generally safe and devoid of adverse effects. One more time. Short-term glucocorticoid ophthalmic drugs in the absence of an infection is generally devoid of adverse effects and considered safe. But in contrast, prolonged therapy may cause cataracts, reduce visual acuity, and cause glaucoma. In addition, there is an increased risk for secondary infection to glucocorticoid-induced suppression of the host defenses. So, because eye infections may present with symptoms that are similar to inflammatory disorders of the eye, prescribing should be done in consult with an ophthalmologist or other specialist with the equipment to verify that symptoms are not caused by an underlying viral or fungal infection. When administered in the presence of these infections, permanent vision loss can occur. Okay. And I say this again because I'll just share it on here and help drive the point home. I actually have a family member who had this happen to them, where they went to the doctor for a painful eye and conjunctiva, had no idea what was going on. And the prescriber gave them ophthalmic glucocorticoids. And when it wasn't getting better, changed to a different glucocorticoid and kind of persisted with it without doing, without sending them to ophthalmology or even an optometrist, for goodness sakes, just a family practice provider, did it. And he actually turned out to have both a fungal and a viral infection in his eye that settled in and severely worsened. And by the days and days, he ended up on glucocorticoids for like 3 weeks. By the time he finally got referred to an eye doctor, ophthalmologist, they, like he went to surgery. He ended up on 9 months of like 3 times a week intraocular injections, a host of like 18 different eye drops that burned and caused him such severe pain and discomfort that he actually had to have like pain management, caused him to have severe anxiety and depression, 9 months of not being able to work because he couldn't stand the light on his one eye. His other eye had to be patched, and he ended up with a corneal transplant before the age of 40. And still now, even post-transplant, has not regained full vision of his eye. And he was a robust, healthy man who liked to shoot and hunt with a rifle and a bow, and his life is not the same because of it. So I have a personal connection to this as well, but it really was, in my opinion, not appropriate at all that he was treated the way he was with an eye disorder. So I share that because it has always stuck with me because it's someone I love. But it's also because I learned that in school. And so I want to make sure that you guys know that, because it's easy in an urgent care or a walk-in clinic, like a little bit of steroids fix everything. But really pay attention to the ocular steroids and know that they have good follow-up, that they have good resources. I'm not saying that you're never going to be told to use them or that they don't have a place. It's just I want you to forever remember that they're not always the best and they're not always the safest thing. And if you're going to use them, it's really something that you're following up with an optometrist or an ophthalmologist, because you don't want to muck around with the eye. Thank you for listening to my soapbox. Okay, then we go for topical drugs for eye infections. I want you to notice that we have not talked about any infection yet. Everything that we've covered that causes the redness, the dripping, whatever, is conjunctivitis or uveitis or whatever it is. It's an inflammatory response. So now we're talking about if someone gets an eye infection, okay? So one of the things to really pay attention to is how do you differentiate between an eye infection and conjunctivitis? So how do we tell if it's allergic conjunctivitis or bacterial or viral or what have you, right? So like, how does one know? By definition, conjunctivitis literally just means inflammation of the conjunctiva. So what is causing that is going to be the big issue here. Sometimes the word you can also use is, I wanted to point this out too before I forget, is injection. It can look like the conjunctiva, you may say look injected, like with the redness that's seen there. So common presentation for bacterial conjunctivitis, and I'm just sharing this more with you guys right now to have in the back of your mind. I want you to make sure you're getting this, is that with bacterial, the complaints are redness and discharge in one eye, typically. So if it's both eyes, we really tend to think more allergy, right? But if it's one eye, it's certainly less likely to be allergic conjunctivitis. The eye can be kind of stuck shut in the morning. The discharge can look purulent throughout the day. It's thick and globular. It can be yellow, white, or green. The discharge differs from that of viral or allergic conjunctivitis, though, because that's mostly watery. You can have a scant, stringy component that is mucusy, kind of. That's okay. But you know what we're talking about when it's a purulent eye. I mean, now we're thinking viral or bacterial. Or excuse me, bacterial more than viral. Viral and allergies can sometimes be a little less or a little more difficult to distinguish. The people with bacterial component oftentimes will have reaccumulation of the purulence within minutes of wiping the lid. But if viral or allergic, the wateriness can kind of go away for a while, and it doesn't necessarily continue to have the mucusy part of it. The common problems with bacterial or conjunctivitis, common bugs is what I'm trying to say. Staph aureus, Streptococcus, H. influenzae, Moraxella catarrhalis are common in adults. Remember that bacterial conjunctivitis is highly contagious and is spread by direct contact with patients and their secretions or with contaminated objects or surfaces. So it has been on college campuses or military dorms or kind of any kind of communal living, you can have an outbreak of conjunctival bacterial issues. You can also have some of the bacterial eye infections that think of like gonorrhea and some of those other weird ones too. Chlamydial infections of the eye, you know, there's some other ones in there. Viral conjunctivitis is typically like adenovirus or one of those serotypes, but you usually also have like adenopathy, sore throat, fever, upper respiratory symptoms. Sometimes the eye is the only symptom you have, but lots of times you have others. It's also highly contagious, and sometimes the conjunctivitis can kind of be the prodrome to a worsening viral infection happening. And it tends to be watery, can be mucoserous, but tends to be more watery. And sometimes people can feel like it's gritty in their eye. That tends to happen more with viral. It's a self-limited process though, and really quote unquote part of a cold. So you just ride it out, right? You can get conjunctivitis from like herpes simplex. And remember, you can also get ophthalmic zoster, so shingles of the eye. And those are whole different kind of ball of wax. So yeah. So kind of a good history, again, is going to be very important in helping make sure we know what we think we're treating and what we're not treating, etc. So they kind of gives you a chart here on, or on your Jiminy Christmas. Table 87.8 is the chart that has the commonly prescribed topical ophthalmic antibacterial agents. Ciprofloxacin is the common one we see a lot. And then the macrolides we can use, the aminoglycosides, gentamicin, tobramycin are popular. We can have a sulfacetamide. And then the polymyxin B containing mixtures are possible there too. And again, those are kind of the general for bacterial conjunctivitis. Reasons, and I mean, it's kind of a guess, honestly, and you can look these up when you're in practice of kind of what's the best for what. I do want to point out that even, again, we have to consider there's reasons that maybe people need ophthalmic urgent referral. And if they have a significant reduction in their visual acuity, that is one. If they feel like they have a foreign body sensation, that they just cannot get their eye open and they have to squeeze it shut, that needs to go. And then really you also want to make sure that you've considered doing the fluorescein. Fluorescein. It's a water-soluble dye that produces that intense green color. So you apply it to the surface of the eye to detect lesions or scratches or things that are foreign objects. Intact areas of the cornea remain uncolored, but abrasions or other defects will turn bright green. It's very helpful. Fluorescein can also be used topically to assess the flow of aqueous humor with eye doctors. People can have an anaphylactic reaction or adverse reactions, but they're very rare to the fluorescein. Rose bangle is what your book talks about being applied to visualize the abrasions of the cornea and conjunctival epithelium. And with that, the injured tissue appears rose-colored with the slit lamp. And then lissamine green is another topical dye, but it causes a lot more stinging, so we don't use that one as much. I wanted to point out too, I know I'm kind of jumping around, but I did go into UpToDate as well and wanted to read to you guys. Again, I know I'm on a kick here, but when you read up on conjunctivitis in UpToDate, it specifically says, ophthalmic corticosteroids, either alone or in combination, in bold letters, have no role in the management of acute conjunctivitis by primary care clinicians. Corticosteroids can cause sight-threatening complications when used inappropriately. Chronic ophthalmic corticosteroid treatment can also cause cataracts and glaucoma, which we said. Ophthalmologists may prescribe them in certain cases of allergy, viral, or keratitis, or blah, 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 but they are in situations which they are clinically supervised by the ophthalmologist. So I just wanted to point that out there. I think you guys will probably never forget it because I won't shut up about it. But okay, that wraps up the eye, and let's move right into our next chapter, 88, which is the skin. All right, chapter 88, drugs for the skin. I don't know if I've said this yet. My two areas of kryptonite, if you will, are dermatology, and today is speaking, but dermatology and orthopedics. I will be the first one to admit that those are not my strong suits. I don't like them in the way that, I don't know, they don't do anything for me. I don't think I'll ever work in dermatology or orthopedics. And I swear I learn it and it goes in one ear and out the other. And just in general, dermatology is tough. I have great respect for dermatology people. I think it would be a challenge to transition into dermatology as an APP. It can be done, but you'd really have to have a good core group of people around you. but it gets wordy to me, like what is a papilloma, what is a blah, blah, blah. So if you fall into that category, I am with you and you are my people. But Laney's does a pretty good job of moving through some of the common skin conditions we're going to see. So we're just going to jump into it, okay? So I love the way Laney says this when they say, when one considers the vast number of skin conditions and the even greater number of pharmacologic agents used in their management, it's easy to see that the topic could alone fill a separate textbook. And I agree with that. So the objective of Laney's is to discuss common conditions commonly managed by the non-specialists, just so like those of us that are not dermatologists can get by. So, as always, Laney goes into first starting with the physiology review, which I appreciate because, again, I need this as much as anybody else. So let's talk about the anatomy of the skin, okay? We have three distinct layers that we definitely need to know about. We have the epidermis, the dermis, and the subcutaneous fat. Just take an image off the internet here to help us look at something. I'm a visual learner, definitely, when it comes to this. So we have the epidermis, the dermis, and then we have this subcutaneous fat layer here within the hypodermis, but they kind of refer to it as both fat. So you have these three layers of protection. Now I want to say something too. Remember that the skin is our biggest organ in our body, and it's the most important first line of defense we have in our body. So the skin integrity, the skin health is extremely important. And so when you start to have breakdown in the skin, cracks in the skin, lesions on the skin, whatever, we have to pay attention to that, right? Okay. So the epidermis is the outermost layer of the skin, and it's composed entirely of closely packed cells, and it has several layers in and of itself. So you have like the basal layer, or also called the stratum germinativum, and then all the cells arise from that. So productions of the new cell within that base layer push the older cells outward so that during their migration, those cells become smaller and flatter. So as those epidermal cells near the surface of the skin, they die and their cytoplasm is converted to keratin, which is a hard, proteinaceous material. And because of the high content of keratin on that outer layer of the epidermis, it's rough or has a horny texture. So that's why our skin is smooth and soft, right? But really, when you look down into it, it's not a baby smooth thing. It's a lot rougher. So keratin tends to be the outer layer of the epidermis that's more hard and protective. Because of the texture, that layer is referred to as the cornified layer or the stratum corneum. The surface of the stratum corneum undergoes continuous exfoliation, a shedding of our skin, and that's what completes the epidermal growth cycle. So it's a highly proliferative organ. It's constantly pushing up new skin cells, and we slough off the dead skin cells. So when people get really dry skin, what does that mean versus someone whose skin is pretty smooth and well hydrated? So when we're talking about retaining moisture into our skin, we have to understand what we're putting the moisturizers on. How is it working in the keratin? How is it working with the epidermis? Those kind of things. The other important part in this is that in addition to those germinal cells, that base layer of the epidermis also contains melanocytes, and that's what gives us our skin color and produces melanin. And after its synthesis with melanocytes, the melanin is transferred to other cells of the epidermis. Our melanin protects our skin against ultraviolet radiation, which is the principal stimulus for melanin production. Okay? So the epidermis, top layer, constantly sloughing. That's where our keratin is, but this is also where we develop our melanin. Then we have our dermis, and as you can see, this is a nice thick layer here. It's under the epidermis, and it's composed largely of connective tissue, primarily collagen. Okay, the function then of the dermis is to provide support and nourishment for the epidermis. So the structures found in the dermis include our nerves, our blood vessels, and our muscle, but it also contains our sweat glands, our sebaceous glands, and our hair follicles. Sebaceous glands secrete the oily composite known as sebum, and almost all of the sebaceous glands are associated with hair follicles. Then we get down into that subcutaneous tissue, and that's mainly the fat, and then that's providing protection and insulation, and it's a reservation of calories, right? So that's a good review of what the skin is composed of in those different layers. So epidermis, dermis, and subcutaneous tissue. So first we're going to talk about drugs for the skin. And they kind of break it down, which I appreciate, into the different kinds of topical formulations in general. So let's review those. In fact, I do think it's worth it to make a kind of another slide here of the different topical formulations. I want you to understand, what the differences are here. Because you see these words slung around a lot and you're like, well, what exactly is that? Okay, so ointment, okay, ointments. Say that 5 times fast. So those are thick, greasy preparations with an oil or petroleum jelly base, and they have very little water. They provide the highest medication absorption. For all of the formulas, ointments are going to hold the best. They have an enhanced penetration that makes them really useful in the management of conditions with thickened skin or inflamed skin, because they're going to sit there, they're going to hold on to it. And it can provide an occlusive film that helps our skin naturally retain moisture. But then it's not a good choice for weeping or oozing skin conditions or areas that have high perspiration, because it kind of traps moisture in. So if you have a condition that's putting out a lot of moisture, an ointment's maybe not the best idea. But it's excellent, excellent, excellent for dry skin conditions. An ointment is excellent, excellent, excellent for dry skin conditions. Okay, then we have creams. That is the emulsion of oil and water. Some have more oil than water or vice versa. This affects the thickness of the skin consistency and how oily or sticky they can feel on the skin. They are not as thick as ointments, but they're thicker than lotions. Creams tend to be good for inflamed skin and dry, sensitive skin. They may or may not be good with secretion skin, so oozing lesions or those things. And creams tend to be more appropriate than ointments for intertriginous areas, so like the groin folds, the folds of skin. Okay. Then we have lotions. I'll let you guys take your notes here. Lotions are water-based, and some may contain alcohol or acids, which can cause a burning sensation. They have little to any oil. So as a result, they feel very light on the skin, and they're lighter than creams, and they're non-greasy, which is great for patients. Patients love that. And they're easy to spread, which makes them a good choice for really large areas or for hairy areas, but they're not good for the folds of our skin. And unlike ointments and creams, they are suitable for oily skin and may even decrease oiliness depending on the ingredients. Okay. Then we have gels. Gels are transparent preparations with a water or alcohol base that usually contains cellulose. They liquefy on the skin on contact, and they tend to have a cooling effect. Because they are non-greasy, they tend to have a drying effect, and gels are good choices for oily skin. They spread easily, so they're good for large areas or hairy areas. They dry clear and invisible, which is nice, especially if they're on the face. They can cause burning, but that's usually because of the inactive ingredients, not the medicine itself. Okay. Then we have foams, and foams are aerated solutions, so they spread easily, they dry quickly, they have no residue. They tend to be good for oily skin or large or hairy areas. Okay. Then we have powders, and powders have talc or cornstarch at the base. They are dry with a silky feel that will reduce friction between surfaces. So our powders are where it's at when we're talking about skin folds. The dryness of the vehicle can help when it's applied to regions that tend to perspire, such as our feet or our axilla. Okay. Pastes are mixtures of an ointment and a powder. The addition of the powder increases adherence to the skin, but the powder will disrupt the occlusive nature of an ointment, allowing air to reach the skin, Most pastes can be used safely in areas that are occluded, which is why a lot of pastes are used for diapers or under diaper for diaper rash. Okay. I put this in here because there's a big difference when you prescribe a medication as an ointment versus a gel versus a paste. There's a big difference when you tell your patient, I want you to get an over-the-counter ointment versus a lotion. So they are different. So that's one of the first things to know, is just know the terminology and what we're using them for. Okay. Next then, let's go back to some of these different drugs that we would use. Oops. Switch, thank you. So we start with the topical glucocorticoids. So they are going to relieve inflammation or itching for a variety of things. They can come as creams, ointments, or gels. The vehicle in which the glucocorticoid is dispersed can enhance or inhibit the therapeutic response, because that will affect how it penetrates to the site of action. Sometimes the vehicle that you use may also provide additional agents as drying or an emollient. Okay. When we talk about topical steroids, we're talking about glucocorticoids, and then we use this term potency. So high potency to low potency, okay? And you have this beautiful table, 88.1, that goes through the potency. So we have super high, high, medium to high, medium, low, and then least potency. It's really important to understand that the intensity of the response to your topical steroid depend not only on the concentration and the potency, but the vehicle employed and the method of application. Okay, so think about this. If you put an occlusive dressing over a steroid cream or something, you can enhance the absorption by tenfold, and thereby greatly increasing the pharmacologic effects. So if you give a highly potent or really potent drug, but you do it in the wrong vehicle, it's not going to be as effective. Okay. So the lowest potency is hydrocortisone, and that's the one that we can find over the counter. The super high potency classes are betamethasone, clobetasol are the two that I see a lot in the hospital in my experience. And those are those ones like that. But the least potency is hydrocortisone, and that's like cortisol 10 that we get over the counter, right? So remember that topical glucocorticoids can be absorbed into systemic circulation, and that extent depends on all those things we just talked about. Absorption is higher from regions where the skin is especially permeable. So face, armpits, eyelids, neck, perineum, and genitalia. And it's much less absorption in the palms or the soles of our feet. And absorption through intact skin is less than through inflamed skin. So we have to pay attention to how we're using these drugs and the vehicle we're using them in. Okay, so for glucocorticoids, we can use them to relieve inflammation or itching, and they can be a drying agent. They have the potential for adverse effects. The adverse effects are higher if you have high potency versus low, or the use of the occlusive dressing or prolonged therapy, or obviously if you use them over a large part of the body. So we can get local reactions. So atrophy of the dermis and epidermis can cause the thinning of the skin, stretch marks, purpura, and telangiectasias. Long-term therapy will probably produce acne or hypertrichosis, which is excessive growth of hair on the face. Then you have the potential for systemic toxicity. Glucocorticoids topically can be absorbed in amounts to provide systemic toxicity. This is really a big deal for children. So if you're applying a topical at-home steroid, maybe, and they have grandkids or kids of their own, it might be worth it to have the conversation of like, hey, you don't want your kids to play in this. You don't want your 1-year-old to accidentally get this and paint themselves in it or something. Important thing to remember, you can absorb enough of systemic topical glucocorticoids to cause adrenal suppression and problems. You have to have respect for these drugs. Typically, they're applied in a thin film and gently rubbed into the skin. Patients are taught not to use the occlusive dressing, so you don't want to go home and then put on Band-Aids and wrap up the thing, unless specifically you as the prescriber know that that's the right thing to do. Same thing though if you have a child or an adult that wears a diaper or plastic pants or something, We have to be aware of that because that would hold in as an occlusive type dressing. Okay, so that's our topical steroids. And we talked about that here. Perfect. Okay, next we have keratolytic, keratolytic agents. So these are the drugs that are going to promote the shedding of the stratum corneum. They are used to treat conditions where there's an overgrowth or abnormal thickening of the skin. So effects can range from peeling up to extensive desquamation of that layer of skin. The two compounds typically for these are salicylic acid and then the sulfur. So salicylic acid promotes desquamation, so skin sloughing, by dissolving the intracellular cement that binds the scales to the stratum corneum. That can be achieved at low concentrations, 3 to 6%. But if you get at high concentrations above 6%, tissue injury is likely. So the low 3 to 6% are used to treat dandruff, seborrheic dermatitis, and acne and psoriasis and things. But when we use those high concentrations, that's when we're getting to use warts and corns. So up to 40% concentration, that's going to do some damage. You're really sloughing off. This drug, salicylic acid, works great because it's readily absorbed through the skin. It's rare to have systemic salicylate toxicity, but it would be the same salicylism as like aspirin. So if they had tinnitus, increased respiratory drive, psychological disturbances, they need to back off on the medicine. The sulfur promotes peeling and drying. Common compounds that will contain sulfur are ones we use for dandruff, acne, psoriasis, and again, seborrheic dermatitis. This one's available in lotion, gels, and shampoos, and it's often used actually with a mix with a low-dose salicylic acid. Okay. When we talk about next is, let me see, do I have, yep, acne. We're jumping into a specific condition. Acne is the most common cause of a dermatologic disease. 85% of teenagers will get acne. Often we get acne into adulthood. Acne sucks. Nobody likes acne. It can be painful. It can be embarrassing, all the things. But that alone accounts for by far and away the most dermatology visits than any other disorder. The costs of acne exceed $1 billion a year. Okay, so there's all these over the counter, there's TV ads, there's all sorts of things to address acne. It's so prevalent and people have it and they hate it and they want to do whatever they can do to treat it. Okay, so let's review the pathophysiology of acne. Acne typically begins in puberty, right? And that makes sense because we have that surge in our hormones, and it tends to be worse in males than females during puberty. We typically think of acne as face, neck, chest, shoulders, and our back. We know that we can have comedones that can be open, so they're oxidized to the air and the surface becomes black, and we call those blackheads. They're very common. Comedone forms when sebum combines with the keratin and creates a plug within the pore. So within this pore here, when I get too much keratin mixed with the sebum, we plug off our pores, and oxidation causes the exposed surface to turn black. If it stays closed and it doesn't get open to air, that's when we get a quote-unquote whitehead. And so that is acne. In its severest form, it can create abscesses and inflammatory cysts. Bad. So as a rule, acne begins to improve after puberty. We level off our hormones, all that stuff levels off our sebum production. We tend to kind of clear up. So most people, not all, but most by our 20s, we don't have that horrible high school acne anymore. But with some people, it continues for decades. Really at play in acne production, and especially in puberty, is the production of androgens during our adolescence. And it's under the influence of androgens and our testosterone that the serum production and the turnover of our follicular epithelial cells are increased. So we get a double whammy. We're just really active turning over that skin. We're growing, we're changing, we're getting muscle, all those things. And at the same time, we're overproducing our sebum. And you get those sebum and keratin mixtures together and you get a plug. and the plug is acne. And then symptoms are intensified, and I want you to hear this and remember this. Symptoms are intensified by the activity of the Propionibacterium acnes, which is a microbe that converts the sebum into irritant fatty acids. That bacterium also releases the chemotactic factors that promote inflammation. So if you have super oily skin, you tend to have that bacteria, and genetics will predispose someone to that combination. Okay, and that's important to understand because now when we want to treat the acne, we need to know all the things we're treating. If you can effectively treat acne in puberty when they have severe acne, it can help prevent scarring and will also limit the duration of their symptoms. And for the majority of teenagers, minimizing the duration of their symptoms is really important for their emotional and psychological development as well. People that have horrible acne in high school have oftentimes just a horrible experience. So it is not something to minimize. It's really important that people get their acne treated because it's important to them. So we always think about, though, our non-drug first, okay? And I could give a talk on this. I do know acne a lot better now because I just went through in the last couple of years a recent teenager of a son that went into puberty, and oh my gosh, you guys, I should show pictures on here of his poor skin. It was honestly the worst I've ever seen in person. And when I mean that, not just his face, but his chest and his back and shoulders. And he is a wrestler, and he was so open and bloody and bleeding, we could hardly get through a wrestling season because number one, he's at risk for so many infections, and number two, he couldn't stop bleeding. You touched any part of his upper chest or body and something below the surface peeled away and bled. It was awful. So I could give a lecture, I swear to you now, because I did a deep dive into acne and wanting to make sure my kid was getting the best stuff, you know. So it's a fascinating topic to me, really. You could get really in depth at it, but let's continue. So in patients, especially with the milder acne, their skin treatment of cleansing their skin is so important. So important. The surface oiliness should be reduced by cleansing with a gentle, non-irritating soap a couple times a day. For me, if you have to be on something for your skin, I think Cetaphil, CeraVe are you go for it. CeraVe to me is by far and away the most effective and best groups of facial cleansing that we have. Care should be taken to avoid irritation from vigorous scrubbing. We're not getting in there and irritating things more, but a nice gentle scrub. Oil-based makeup or moisturizers should not be used, and additional measures could be needed for some individuals. Sometimes you have to get in there and extract their blackheads because they're not going to clear. They're plugged, they're stuck, there ain't nothing we're going to do. Diet does not matter. Whether or not they exercise doesn't typically matter. It may worsen it, but even if you laid in a dark room and never went outside or moved your body, you're still going to have horrible acne. So those things are not true. So really spending money on a good Cetaphil, CeraVe, to me, you guys, they blow Neutrogena, all the things out of the water. Proactive is now over the counter. I would argue that they probably also have great resources as well. But really, I tell the patients that I've dealt with this, or to give advice to people, you got to spend the money on good facial cleansing. Okay. Then we can get into drug therapy. So we have two major groups. We have topical and oral. The topicals have antibiotics or retinoids. Drug selection is based on the severity of symptoms. Mild, they typically can have a topical therapy. When they're more severe, oral therapy is needed. Moderate sometimes can have oral antibiotics, so on and so forth. Okay, so let's get into these topical drugs. The first one is antibiotics, and that is our class we're dealing with. Remember, so we could have our antibiotic class or the retinoid. So under the antibiotics, the first one is benzoyl peroxide, BP. If you remember anything about acne, remember BP. It's going to be your first line drug for mild to moderate acne. It's both an antibiotic and a keratolytic. Okay, it's phenomenal. It has revised the acne world when we figured out BP is where it's at. Okay, so it's doing two things. It's going to be treating that bacterium we talked about, and it's a keratolytic. It's helping remove the dead skin cells, and it's treating at the same time. You can see improvement within days of starting treatment. They are going to suppress the growth of the P. acnes, and that mechanism is presumed to be through the release of active oxygenation. And the benzoyl peroxide can reduce the inflammation, and it promotes the peeling of that horny layer of the epidermis. It does not promote emergence of resistant P. acnes. So that's a big deal. It is safe, it works well, it is the mainstay of treatment. If you are going to spend money on an over-the-counter medication for a loved one or a patient or your child or whatever, and you want to spend money on something and it doesn't have benzoyl peroxide or you've not used that yet, you're not doing it right. You got to have the BP. Okay. It can cause drying and peeling of the skin. You can possibly get local irritation, like some people may not tolerate it, but the frequency should just be reduced and not stopped. There has been associated potential serious hypersensitivity, seems to be in patients with asthma. So yes, if you have an asthmatic teenager, maybe that's not the drug of choice. But for most people, you got to have BP at some form of that in there. It can come as a cream, a foam, a gel, a lotion. Typically, they tell patients to put a thin film once daily initially and can go up to 2 to 3 times a day as needed. If it's in your cleanser, though, you just wash once or twice daily. I would always tell people 2 times a day unless they get the hypersensitivity from it. If excessive stinging continues after you put it on, you can wash it off with mild soap and then resume the use the next day. So you kind of learn how to put it on. Okay, then under antibiotics, we have topical clindamycin and erythromycin. Okay, so this is drugs that also will suppress the growth of the P. acnes, but these drugs also decrease inflammation, so they're good. Monotherapy with either drug will quickly lead to the resistance. So these drugs are combined with BP, that's right. So benzamycin, benzaclin, some of those drugs, and that's the reason for it. And those in combination can work very, very well as well. Okay. Then we have the drug dapsone, and it's been used for decades. It actually is the drug for leprosy. So if you ever had a question about what drug that treats leprosy is also good for acne, it is dapsone. The drug yields a modest decrease in inflammation and the number of lesions, but it can cause oiliness or it can cause peeling, dryness, and even redness. It is usually caused by the vehicle that you're using it in. It can be given topical or oral. Oral's like leprosy. Topically, we're talking about here, can work really well. There's a risk for hemolytic anemia with patients with the G6PD deficiency, but the risk is very slight. Unlike oral dapsone, the topical is not known to cause peripheral neuropathy. The interesting thing is if you combine dapsone with the BP, you can turn the skin yellow or orange. So that might not go well. And then let's talk about the next class of drugs is our retinoids, okay? Retinoids are a derivative of vitamin A, and they are also considered the cornerstone of acne therapy. The drugs can help unplug the existing comedones and prevent development of new ones. The retinoids are what actually tighten the pore, the hole of the pore, so it's much smaller. So number one, it ejects out the blackheads over time, and 2, prevent that pore from staying open to refill. They can also be helpful because they're reducing inflammation, but they also then can help improve the penetration of the other topical agents. Topical retinoids are approved for acne and can be used alone or with combination. Typically, you'll have a topical and maybe an oral antibiotic at this stage of acne. Adapalene became the first topical retinoid approved for the over-the-counter treatment in people 12 and older, and adapalene is what's in Proactiv. A lot of times, if you look at the back of Proactiv drugs, it's either adapalene alone or it's BP and adapalene. So you're going to see it. Those are out there. The tretinoin, I can't say it, tretinoin, is used for acne and fine lines and wrinkles. But this is Retin-A. I think maybe people have heard of that the most. If it's formulated for wrinkles, it's a different name. The topical tretinoin should not be confused with isotretinoin, which is a different medication that we talk about later. You can use the tretinoin for acne. So mild to moderate acne uses tretinoin. The benefits derive from normalizing the hyperproliferation of epithelial cells within the hair follicle, because remember, the sebum is almost always associated with the hair follicle. Tretinoin causes thinning of the stratum corneum and can thereby facilitate penetration of the other drugs. And the therapeutic effects can be enhanced by combining it with BP, topical antibiotics, and oral antibiotics. When you use it for wrinkles, I want to point out, though, that the benefits may derive from suppressing genes that code for proteases that break down collagen and elastin, but it's important to note that doesn't actually repair deep, coarse wrinkles or like repair skin. It's kind of a, once you stop using it, the wrinkles were likely to come back. Okay, adverse effects of the tretinoin. They're localized, but absorption can be sufficient to cause systemic. So in patients who have super sensitive skin, tretinoin may cause blistering, peeling, crusting, edema. These effects can be intensified by using the abrasive soaps or because they're also on the keratolytic agents. So those therapies should be discontinued before beginning tretinoin therapy. The skin reactions with the two formulas like Retin-A Retin-A Micro tend to be less intense than the older formulation, so we see a lot better version of Retin-A Micro. Really, really important thing though, tretinoin will cause you to sunburn, like easily, like a lot. Like 3 minutes outside to go walk to the shed and get the brooms out for mom and come back in and put them in the garage and then walk back out to the shed and then come back. Like you can sunburn. So SPF of 15 or greater and have protective clothing. If you are severely sunburned, don't put it on. And then adapalene. It's similar to the tretinoin. It works a little differently. The drug reduces the formation of comedones and inflammatory lesions, but it takes 8 to 12 weeks to really work. During the early weeks, adapalene may appear to exacerbate acne. Okay, it actually identifies already of those early acne things that maybe you just hadn't seen yet, and it's literally pushing it to the surface. So you first start using it and you're like, what the hey, I have broken out so bad. That's a good thing, it's working. Okay, and then over time it'll get better. Okay, then we go to the cherolytic agents, azelaic acid and salicylic acid. So these drugs then are going to promote the shedding of that outermost layer of the epidermal skin. So we use them to treat acne specifically. So azelaic acid is a topical drug for the treatment of mild to moderate acne, and it also can be used for rosacea, which is kind of similar to acne in some ways. It's going to suppress the growth of the P. acnes bacterium and decrease the proliferation of the keratinocytes, decreasing the thickness of the stratum corneum. For severe acne, it was much less effective than oral tretinoin, so that's why tretinoin is so popular. It can have some bad side effects, burning, itching, stinging, etc., and it can reduce pigmentation in patients with dark complexions, so they have to be monitored. If it starts to change the color of their skin, they're probably not going to be very happy with that. Salicylic acid is very common over the counter. It's very common in a lot of the Neutrogenas and those kind of things of the world. It's for mild to moderate acne. It can cause local irritation. It may cause some sloughing of the skin or mild peeling. The problem is that could people have a severe allergic reaction? That's a possibility. Salicylate toxicity is not typically a problem when you're only putting it on the face, but if you're starting to use it face, trunk, back, and other locations, you could absorb enough to have salicylism. So you have to monitor and treat and educate your patients for that. All of these medicines also should come with a sunburning warning. Okay. Now into the oral drugs for acne. So we talked to these ones were the topical kind of drug therapies, and now we're getting into more of the oral therapies. So now we can also do our oral antibiotics. So that is specifically to try to suppress inflammation by decreasing the growth of the bacterium on your skin. They are often used in combination with that topical retinoid. The ones you should think of are doxycycline and minocycline. Those are your agents of choice. You can have tetracycline and erythromycin, but they have more resistance to them. I just don't see that. It's kind of fallen out of favor. However, like with any antibiotic, it takes some time, often 3 to 6 months before you get the maximal effect from it. So after symptoms have been controlled, then with the oral antibiotic, they switch to the topical antibiotic for long-term maintenance. All right, let's get to the big boy, the big one, the really interesting one that we always have to know about. In fact, I'm going to give you a new screen for that. So isotretinoin, which is Accutane, trade name. Okay. This is the derivative of vitamin A, and it's used to treat severe nodular or cystic acne vulgaris. Okay. So that's like the most severe form of acne. It's a condition for which this drug is highly effective, and for most patients, a single course of therapy can produce complete and prolonged remission. Because isotretinoin can cause some serious side effects, its use is restricted to patients with severe, disfiguring acne that has not responded to more conventional treatments, including oral antibiotics. It has several actions that work well. It decreases sebum production, decreases sebaceous gland size, decreases inflammation, and decreases keratinization. So you are decreasing the availability of sebum, which is the nutrient for that mycobacterium, and it greatly lowers the skin population of that microbe. Okay, so when I'm talking serious, disfiguring, potentially scarring, let's go through a couple of pictures on the internet that'll help us realize really what this is. This one here, acne vulgaris. Let's see. This guy here, acne vulgaris. Look at that cyst, that nodular there. Okay. This, I'm not even joking, is very similar to what my son's back looked like all the way up his neck. These are all these big, cystic, gnarly, gross, awful things, right? So this is acne vulgaris. This is acne vulgaris, okay? These are the acnes that are no joke. This is acne vulgaris, okay? And I'm showing you that because people can be like, I have such bad acne. And it is bad to them. I'm not minimizing that. But to truly be acne vulgaris, that we need to be on the tretinoin, isotretinoin on Accutane, I mean, this is for this, okay? Let's find, so this is finding, this is someone's skin after it's beginning to go away, the pits and the pockets, it's scarring. And to people, this is disfiguring. So it's important to treat the acne vulgaris, or this is what people's skin can look like afterwards. And that can be very, very hard for them psychologically to deal with, this kind of pitting and poxing and scarring. So I share that because it's not something little. We have to take this very seriously. So people work their way up. They've tried all the other things. They've tried the BP, the salicylates, the adapalene. We've washed well. We've done the topical steroids. We've tried the 6 months of oral steroids. Nothing's getting better. They work their way up to Accutane. The problem is that Accutane carries a really high risk of severe structural and cognitive defects in the developing fetus. It's also associated with increased risk for spontaneous abortion. So it has a black box system. It has a very, very monitored REMS program. You have to be a certain prescriber to even be able to prescribe it. The pharmacy asks you a gazillion questions, and as a parent, you sign your life away to put your kid on it. In order to put a female teenager on Accutane, it is a way more extensive education and thing, because it is so bad for a developing baby. Like, you're not going to have a good outcome if a teenager, a female's on Accutane and then gets pregnant. She likely may not even be able to carry the baby to term, and the baby's going to have birth defects. So people take that very seriously. The physical effects are not something to belittle either. Not many people get to be on Accutane and just breeze through it. It works really well, so they do it, but they probably have some kind of effect from it that maybe isn't pleasant. For a lot of people, 80% are going to get nosebleeds. And these are nosebleeds where I'm talking like nosebleeds, like you got to leave high school class nosebleed, ruining your t-shirt nosebleeds, okay? Then inflammation of the lips, huge. when we talk about Accutane and you're putting somebody on them, I mean, they are going to bathe their lips in Aquaphor. You essentially are going to put so much ointment on your lips, you're going to look funny, because if you don't, your lips are going to slough, okay? Inflammation of the eyes and dry eyes, no joke. Itching of the skin, the nose, and the mouth, no joke. So those ones that I've read off of are very common in Accutane, and we're talking people are on it for months at a time. So they kind of have to like grin and bear it because it's working probably very well, but maybe they're getting a daily nosebleed, maybe their eyes are so dry and their lips are just cracked and killing them, okay? Then, so those are the very common ones. Almost, I would say you would expect you're likely to have one of the three. Then many patients can experience some other things that are more troublesome. About 15% will get bone and joint pain. And we're talking muscle pain, tenderness, stiffness. Some people have said they start walking like an 80-year-old. Like, it's just like, why do I ache? Like I'm getting sick, but I'm not. That could be from the isotretinoin, okay? And the kids that use this, about 30% are going to have back pain. So you have to worry, though, because premature epiphyseal closure may be a problem for those who are still growing. So we don't use it typically in young puberty. And then you can have skin rashes throughout your body, not even on your face or your acne areas, headache, hair loss, and peeling of the skin of the palms and soles. And we're talking significant peeling that could be tender and painful. There's also a risk for reduced night vision, and it can come on suddenly, so you have to be very careful if they're of driving age at nighttime. And their risk of sunburn goes through the roof. Their skin becomes so sensitive to UV light that we're talking the potential for burning here, okay? Like if I had a child who was a 16-year-old in Accutane and we were going to go to Mexico for a vacation, I would probably keep them covered head to toe in their skin the entire time, because I think the odds of you not getting sunburned if you show any of your skin for even a short period of time would be that low. The other thing is that it also increases the risk for several big problems, okay? First of all, pseudotumor cerebri, benign elevation of your intracranial pressure, okay? We don't want that. Pancreatitis, don't want that. Hearing impairment with or without tinnitus, we don't want that. Decreased bone mineral density, well, these are 15, 16, 17-year-old kids maybe, we don't want that. And then mental health changes, including depression and suicide, and maybe some mood stuff too. It is a big thing to monitor the mood, okay? The other thing is that it can also increase your triglyceride levels, and so you really shouldn't have any alcohol in that as well, because seriously, mixing alcohol in this could give you hypertriglyceridemia. Bad. The depression part of it is not to be belittled. I have said that. In fact, like they oftentimes in a lot of offices will be giving the kids or the teenagers or the young adults, they are giving them the PHQ-9 to screen for depression, like right away. So that's how closely they're really trying to monitoring them. A lot of parent education is happening to watch for the moods of their children, because people have had thoughts of suicide on this drug. So you have to have a lot of education for that. Okay. Then we also monitor liver function tests pretty regularly. So lots of lab work can be with this to monitor for their triglycerides and their LFTs and their pancreas enzymes. And that's monitoring them without symptoms. Like you're just going to get your lab drawn every so often for the first few weeks, first few months of isotretinoin. And for some, if you have a 15-year-old that's really needle phobic, that's a big deal. So, this is not an easy thing to ask a child or a young adult or an adolescent to do. It's a significant impact on their life, most typically. Probably should really avoid vitamin A because it's so closely a relative. It could kind of intensify isotretinoin, so we say not to do that. and don't take tetracycline. Okay. Your book goes into the iPledge program. It's a risk management program designed to ensure that no woman starting isotretinoin is pregnant and that no woman taking it becomes pregnant. So under the iPledge, all transactions involving this drug must be processed through a central automated system. It tracks and verifies critical elements that control access to the drug. So you don't get it if you don't do iPledge. That's just the way it is. For females, okay, each patient must receive oral and written warnings about the risk during pregnancy. Pregnancy must be ruled out before you prescribe it, and again before each monthly refill. The patient must undergo 2 pregnancy tests, both of which must be negative before the initial prescription. For the monthly refills, only 1 negative test is required. Each patient must use 2 forms of birth control, even if one of them is tubal ligation or vasectomy of the male partner. Okay, so if you have a 15-year-old female that's a very not sexually active teenager, or parents that are very conservative or whatever, I mean, this could be a big deal to say you have to put your daughter on birth control or she won't get this drug. That's the way that it works. So this can be messy in some situations. And contraceptives, as we have talked about, can be failed or can fail. So that's why you have to have 2. You have to have birth control measures in place at least 1 month before starting and have to continue for 1 month after starting, unless they have a hysterectomy. They do allow you to kind of sign off between the parent and the female that you are committing to total abstinence. That can be allowed, but I've even seen that be a problem for some people as well to get it. So it's a big deal. And then to be a prescriber, you also have to pledge that you're going to follow with that and you sign off on all of that. So to be an Accutane prescriber is also a big deal. Okay. So there's a lot of information in your book about the Accutane. Read it, be familiar with it. Accutane is one of those kind of questions you could get on a board certification exam as well. All right, and then we went into the hormonal agents for acne. Okay, so specifically we're still on acne. You can use combination oral contraceptives or you can use spironolactone. For the oral contraceptives, they're in your book. And in order to get this for use of acne, you have to be at least 15 years old for a female, have reached your menarche, which is you've had menstruation, and you've not responded to topical drugs. Acne can still take 6 or more months to benefit, but the benefits are going to be due to the estrogen, not the progestin. The 2 mechanisms mean that the estrogen will suppress ovarian androgen production, and 2 will increase production of the sex hormone binding globulin. That's a protein that binds that androgens and renders them inactive, so it helps decrease the sebum. And then we have the option of spironolactone, which blocks a variety of steroid receptors, including those for aldosterone and sex hormones. So if you block aldosterone receptors, then you can help with acne. As a rule, spironolactone is only added to the regimen after oral contraceptives have proved inadequate. And that sequence makes sense because spironolactone is also teratogenic, so you have to make sure about contraceptive as well. Spironolactone also can mess with their periods and cause menstrual irregularities, breast tenderness, and then we have the possibility of lab abnormalities. So we don't jump straight to spironolactone in children, right? That's just not going to be our jam. Then we have a nice little resource here in your book as well. That has the diagnosis of acne and kind of a little bit of a treatment line here. First line, alternative, mild, moderate, severe. It's very useful for answering questions. All right, the last topic that they throw on in here real quick are a couple of things. One is sunscreens. Sunlight can cause a variety of damages to our skin. We can get premature aging, we can get skin cancers, and we could actually have immunosuppression. Using a sunscreen would be very helpful. Solar UV radiation that reaches the Earth's surface is classified by wavelengths as 2 types. So you have ultraviolet B or ultraviolet A. So UVB or UVA. Most of this UV is UVA. So when we're talking about sunblock, we're really trying to block UVA. UVA penetrates the epidermis and deep into the dermis, whereas UVB penetrates into the dermis, but no deeper. Tanning and sunburn are primarily caused by UVB. But because the UVA penetrates much deeper, the UVA is the primary cause of immunosuppression, photosensitivity, drug reactions, and photoaging of the skin. But both UVA and UVB will promote damage to DNA, so they both can cause premyelinic actinic keratoses, basal cell carcinoma, squamous cell carcinoma, and malignant and non-malignant melanomas. So the benefits of sunscreen work because they impede the penetration of UV radiation to viable cells of the skin, so they can protect against the harmful effects of UV radiation. There's two categories of sunscreens, organic, which are chemical, and inorganic, which is physical. Organic screens absorb the UV radiation and dissipate it as heat. The inorganic screens scatter the UV radiation. We now, at the time of this book, had 17 compounds approved by the US FDA for sunscreens, and your book gives us a nice little chart here to look at that show us the UVB, UVA, and UVA1. And so the inorganic physical sunscreens that contain titanium dioxide or zinc oxide cover all of it. So obviously we would consider those to be the safest. Most of the 15 sunscreens are considered organic that are on there. Almost all of them absorb UVB, but only 6 absorb UVA, and only 1, avobenzone, absorbs UVA1. So to provide protection against all of that, products must contain of mixtures, one of which must be the avobenzone, which is avobenzone, this one here. Okay, the inorganic physical screens act as a barrier to the sun's rays. So rather than absorbing them, they reflect and scatter the sunlight, and they prevent the penetration into your skin. That's the titanium dioxide and zinc oxide. Those compounds are especially useful for protecting limited areas like your nose, lips, or your ears. In the formulations from today, the titanium dioxide and the zinc oxide are micronized. So unlike the older ones, which were white, we now have the ones that are clear, and so people like them better. You know, you used to laugh, you'd see people covered head and toe in the white paste. Well, now we have this micronized version, and we can spray it on and it's clear, like nobody has to know you're covered in sunscreen. And then sunscreen products are labeled as sun protection factor, which is SPF. So that's the index of protection against UVB. So SPF does not say anything about UVA. It's only referring to UVB. The relationship between your sun protection factor and protection against sunburn is not linear. So an SPF of 30 does not indicate twice as much protection as an SPF of 15. Actually, as the SPF increases, the increment in protection gets progressively smaller. So an SPF of 15 blocks 93% of UVB. An SPF of 30 blocks 96.7, and an SPF of 40 is 97. So because SPF values above 30 only provide small additional benefit, the FDA no longer allows companies to advertise high SPF like SPF 80. Instead, products with SPF greater than 50 can only be labeled as SPF 50 plus. So that's a fancy way of knowing about your sunscreens. So all sunscreens, again, protect against UVB, but only some against UVA. The ones that protect against A and B are labeled with the words broad spectrum. Product labeling allows consumers to distinguish between these three basic groups of sunscreens. Okay, it's all in your book. Highly protective, broad spectrum sunscreens with an SPF of 15 or higher that protect against sunburn, skin cancer, and photoaging. Moderately protective, broad spectrum sunscreens with an SPF of 2 to 14 that protect against sunburn but do not protect against skin cancer and photoaging. And then least protective sunscreens with UVB protection only that do not protect against sunburn and do not protect against skin cancer and photoaging. If a product is moderately protective and least protective, they must also carry a warning that they do not protect against skin cancer or photoaging. So it's actually a pretty highly regulated field. I don't know if we would always appreciate that about our sun protection, but it's the truth. Now we have sunscreens that are also claiming to be waterproof or sweatproof. They can claim to be water resistant or sweat resistant, but they can't say waterproof or sweat proof anymore. They must indicate how long the resistance lasts as determined by lab testing. So if a product that retained their SPF after 40 minutes of water would be labeled water resistant 40 minutes, et cetera, et cetera. So you must reapply after swimming or sweating from that time frame to still get the benefits of the sunscreen. All right, the next drug to talk about is eczema. Eczema is a very common condition. It's atopic dermatitis. It's a chronic inflammatory skin disease. It has dry, scaly skin and intense pruritus that often leads to scratching and rubbing, which in turn leads to erythema, abrasions, rash, erosions with an exudate, and increased susceptibility to skin infections. Continued scratching will result in lichenification of the affected skin. The underlying cause is abnormality of our active T lymphocytes. First line therapy for eczema. Okay, you're going to see eczema all the time. First line therapy, Cetaphil moisturizing cream or Eucerin original cream and topical glucocorticoids. Unfortunately, the topical glucocorticoids can cause atrophy, hypopigmentation, and telangiectasia, and in high doses, possible systemic effects, including adrenal suppression. If the topical glucocorticoids are insufficient, patients may be treated with a topical immunosuppressant. A sedating antihistamine can also help controlling itch at night. And people with eczema sometimes do itch at night, like a lot. We do have the possibility of topical immunosuppressants, which is tacrolimus and pimecrolimus. So atopic dermatitis can use those. Both drugs are calcineurin inhibitors. They can protect against atopic dermatitis, but they pose a risk for skin cancer and lymphoma. So they're considered second line and should be reserved for patients who have not responded to steroids. Tacrolimus is available as an ointment for moderate to severe atopic dermatitis. There is concern that there's that risk for cancer. Pimecrolimus, which is Elidel, is a topical immunosuppressant approved for mild to moderate as well. So going through those pretty quickly. Next one is the phosphodiesterase 4 inhibitor. Not a 5, but a 4, which is crisaborole, which is Eucrisa. It's a novel agent for atopic dermatitis. It inhibits PDE4, which in turn leads to reduction in cytokines and skin inflammation. Patients should apply a thin layer of the ointment twice daily to the affected areas. Crisaborole is generally well tolerated. The most common adverse effects are burning and stinging at the application site. Hypersensitivity reactions, including contact urticaria, have occurred. But it's a good option for people that's not an immunosuppressant. Then we go into warts. We have the topical warts that we would often be asked to treat. Warts, remember, are HPV, and there's 100 types of that, so it's hard to know exactly what type of wart they have. Most warts resolve spontaneously within a few months, but some can last for years. And warts of the feet can hurt like the dickens, so people oftentimes really do not want that. Then we have the difference of venereal warts, which are warts around the cervix, vulva, urethra, glans, penis, and anal canal. Those ones are caused by two types of HPV, 6 and 11. And if we, HPV is a whole nother thing. The important part I wanted you to know is that the Gardasil, the HPV vaccine, can protect against all 4 types of HPV and can help prevent venereal warts as well as cancer of the cervix, just FYI. Remember that infection with HPV can be transmitted by sexual contact, so individuals with anal or genital warts need to be educated and warned that they will likely transmit the infection to sexual partners. So partners should also be monitored or examined, and then the condoms can reduce the risk for transmission. Okay. Genital warts can also be removed with topical drugs or with cryotherapy like freezing, electrodesiccation, destruction with an electric current, laser surgery, or conventional surgery. Those measures are much faster than the drugs but can be more painful. And neither the drugs nor the physical measures will eradicate the virus because even after the wart's removed, the virus remains. Table 88.4 has all that information and a nice table for you to use. The drugs that are used to remove the venereal warts can be divided into 2 groups. So we have agents that have to be done by a healthcare provider and then agents that can be at home. With both groups, the application is done repeatedly until the wart disappears. So as providers, we can apply podothalin, trichloroacetic acid, TCA, and bichloroacetic acid, BCA. At home, they can apply padoxifil, imiquimod, and the cunnicatechols. All of these drugs act slowly, they can hurt and cause local irritation, etc. Okay, so as a provider, what are the drugs we could do? Podothalin is used primarily for perianal and venereal warts. It's not very effective against the common wart. It's a mixture of some resins. The actions lead to cell death that inhibit DNA synthesis and mitosis and lead to cell death and erosion of the wart. These preparations are highly caustic and should be applied only by a trained clinician. To minimize the risk for toxicity from systemic absorption, the resin should be washed off with alcohol or soap after a few hours. And you can only do a small surface area at a time. It can be absorbed in amounts to cause systemic toxicity, so you could have neuropathy, kidney damage, or blood dyscrasias. It's also teratogenic and cannot be used during pregnancy. Okay, it's a topical solution, and you have to do it to a small area. The patient-applied drugs that I want you guys to know of is imiquimod. It stimulates the production of interferon alpha, tumor necrosis factor, and other interleukins, and intensifies immune response to HPV. The imiquimod has no direct antiviral effects of its own. The principal adverse effects are erythema, erosion, and flaking at the site of administration. Local itching, burning, and pain may also occur. Okay, and then Podothylox is another drug that I want you just to know and hear of it. And then let's go down to the common warts. Those are Verruca vulgaris. They're hard, rough, horny papules. They can appear anywhere on the body, but they're most common on the hands and the feet. They may be removed by physical procedures or those topical drugs as well. The book goes into cosmetic briefly to understand Botox and how that works. It could be fatal if you eat foods contaminated with C. botulinum, but we give it in small amounts for cosmetics because it's not toxic at those levels. That's all I want you really to know about that. Then we have our drugs for seborrheic dermatitis and dandruff. You guys can read through there. Ketoconazole is a really good antifungal drug that can be used as well in shampoos and creams. And then to point out, I'm kind of trying to get through this, the drugs for hair loss, topical minoxidil, which is a blood pressure drug, but we can give it, that is what we call Rogaine, right? And then finasteride is also a drug that could be used for male pattern baldness. Wanted to point that out. And then Vaniqua is an old drug with a new indication and new formulation that's been available since 1990 for systemic therapy of African trypanosomiasis, sleeping sickness, but it's available for cream by women to remove facial hair. I just wanted to point that out, that that's a thing that's out there as well. Okay, I do want to talk quickly about impetigo. We think of it as a child thing that you get in young classrooms, or those things, but anybody can get it. It's the most common bacterial infection of the skin from Staph aureus. It's seen in 2 to 5 year olds, but think especially in football or wrestling or gyms. It's highly contagious and usually spread person to person.